I really wanted to say a little bit to this audience about the addicted driver. I've come to this space, as the introduction said, from policing and clinical medicine. And it struck me in the last couple of years since I left working for Victoria Police and have been actually treating drug addicts, that there is a group of people that the current responses don't necessarily deal with. So the words are good, aren't they? Okay. Firstly, I wanted to raise the question of which drugs should we worry about. There's a lot of papers out there now talking about the road problems and the impairment caused by a whole range of drugs, both licit and illicit. And part of what's informed me follows from the material that Philip presented earlier. Back in the 90s, Olaf Drummer and his team presented that groundbreaking evidence around the responsibility of drugs in causing fatal accidents. I was fascinated to know if non-fatal accidents were different. And the larger of the bars are the non-fatal accidents. This is part of a study which I started some years ago, and I'm really pleased to say is continuing, even though I've left the Victoria Police. I presented at ICAT's last meeting the preliminary data looking at 1,809 drivers, and that's the larger of the bars. And as you can see, there are some real problems. Unfortunately, the reformatting of actually, it looks all right up there. No, it's not. The reformatting of the slides made the legend a bit hard to follow. But there are a couple of things that really stood out for me. One is that if you look at low-dose alcohol, the risk of a non-fatal collision is much greater than I would have predicted, and certainly is much greater than you would have predicted just from the fatality data alone. And the real standout in that slide is the combination of alcohol and THC. This is true THC, Mark. And any amount of alcohol with any amount of THC produces an odds ratio of responsibility for collision of over 60. Just the presence of THC alone gives you an odds ratio of 7. And if the THC is greater than 5, then you get an odds ratio of 8. So I don't think we can ignore THC. The stimulants we found really hard to study, and although there's an odds ratio there for non-fatal collision of 8, there was no driver in this cohort that had stimulants alone. So it's almost impossible to say what was the contribution of stimulants by themselves. And the one thing that I have data on that the fatality data didn't was the benzodiazepines, and just the presence of a benzodiazepine was associated with an odds ratio of 13. In this early data, we had a go at looking at different benzos, and it does appear that diazepam is particularly problematic, at least in the Victorian context. And the one standout, of course, was alprazolam, where 94%, there were 44 drivers who had alprazolam in their blood. 41 of them caused the collision in which they were injured, and the other 3 contributed. Since this study, alprazolam has been added to the schedule of drugs of addiction. So it'll be interesting to see if that changes as alprazolam becomes more difficult to obtain. The street price has gone up, and presumably other benzos will take their place. And the other, unfortunately, the legend's been screwed for this one too. There appeared to be a dose relationship for diazepam. The more diazepam you had, the more likely you were to be responsible for the collision in which you're injured. The tall bar that hits the top is people with toxic levels of diazepam, and 100% of them were responsible for the collision in which they're injured. The combination of diazepam and alcohol, any amount of alcohol, any level of diazepam, 98% were responsible for the collision, and hence my comment yesterday that people taking benzos should have 00 BAC. The other challenge, of course, is what happens with combinations. If you look at the cohort of drivers who were drug and alcohol free, about 40% of them were responsible for the collision, about 40% of them were not responsible, and 20% made a contribution. If there was one potentially impairing drug, 70% responsible. If there were two, it's 80%. If there were 3 drugs, 90%. And if people had 4 or more drugs, then they were all responsible. And again, this makes common sense, and combining sedative drugs with alcohol or sedative drugs with each other is clearly an issue. Now, the point that I want to make, and it follows nicely from Jane's comment this morning, was that drug addiction needs to be taken quite differently. We clearly have 2 sets of drivers, and it was alluded to yesterday. We have those people who use drugs recreationally and may occasionally combine drug use and driving. We have those people who use drugs all the time and who may in fact be dependent. So drug use is voluntary, and in that group of people it's perfectly reasonable to have a program that says that they have an interlock and they don't drink, or that they attend at the police station weekly and have a drug screen which is negative. But the group of people who are addicted to drugs are not people who just use a lot of drugs. They are people whose brains have changed. And there was this paper, Alan Leschner's, which is now 30 years old, in Nature, in which he said addiction is a brain disease and it matters. And for a lot of people, that is a new concept. At its core, addiction is a biological process. The addict's brain is changed. And the ability to do neuroimaging and to look at brain function has shown us that those people who have become addicted to drugs have changed their brains. And therefore, the punitive approach of the criminal justice system may not be totally appropriate if we want to change their behaviour. And that is so obvious. Every conference I've been to since I've had an interest in road safety, there's been discussion of the recidivist drink driver. Why have we not been able to do anything with the recidivist drink driver? Because we haven't ever had a program that looks at what they've done to their brain. We've taken a moral judgment view rather than a more therapeutic view. All of the addicted drugs have at their core some action on the dopamine pathways, ending up with the person initially using the drug for some sort of reward, for pleasure, but eventually ending up with a compulsion to keep using it. So as Nora Volkov said, the blunted pathways that follow continuous use mean that addicts find it harder and harder to feel normal. They find it harder and harder to feel good. And so they get caught in this cycle of intoxication with impaired awareness of self, losing control, maybe in binges, maybe for years at a time, attempting to stop and having a period of withdrawal when they feel terrible, and they start craving to start it all again. And we know that we can break that cycle. We have the ability to reduce cravings. There are a number of medications with well-proven effects on craving, regardless of which drug you're talking about. We know that psychological techniques will improve self-awareness, will help people to rethink where they are in the cycle of change and whether they want to keep going around and round and round the circle. And so we have the ability to break that part of the cycle. And we can actively manage drug withdrawal so people don't feel terrible and therefore can get to a point of sobriety where they can actually think about whether they want to continue in the cycle. Now, a lot of people have said to me since I've gone into full-time management of drug abuse, how frustrating that must be working with those awful people. Well, I have to say to you that our success rate is about the same as every other major department in the hospital. 40 to 60% of people who are being treated for addictions are doing okay at any particular point in time, which is not bad compared to the failure rates in diabetes, hypertension, asthma. And when my patients front the emergency department, whether drug affected or drunk, they get judged. You know, here's another one of those useless patients from addiction medicine. But no one does that to the person who presents with status asthmaticus. You know, here's another one of those useless asthmatics wheezing again. Nobody says to the person whose blood pressure is out of control, you idiots, you didn't take your tablets. But they do that to my patients. Beautiful. The reality is that the addicted patient spends their time, you need to find the reference is in the PowerPoint, so you'll need to have a look at the paper. But patients spend their time percolating between stable in the community, in recovery in the community, entering or re-entering treatment, and incarcerated. But if you look at the figures, about 2/3, 3/4 of patients are stable at any given time. And the important thing for this particular conference is that treatment does not need to be voluntary to be effective. Coercive treatment works. The one variable that we know is very important in good outcomes is time in treatment. If you take the treatment of methamphetamine abuse, most studies show a failure at about 12 weeks. That seems to be the critical time for people who are struggling with the stimulants. The Victorian Health Department has just advertised the availability of funds for methamphetamine treatment for 10 weeks. What does that tell you? They want good results. They're going to have them for just long enough to be doing okay, but before they failed. If we're serious about these things, we need to have long-term, sustainable treatments. So we've got these well-developed responses to alcohol, but we haven't actually tackled the recidivist drink driver particularly effectively. We've got well-established legislation, at least in Australia, looking at methamphetamine, MDMA and cannabis, but we struggle, and we will struggle for some time to know how to deal with the benzos, with the prescribed painkillers, and of course the combinations. So I'd like to suggest that there are some principles that we should take with us in thinking about the response to drug driving. One is that road safety is not optional. I put there one of the works that amused me when I first started studying criminology. It's Norval and Morris's book from 1970, The Honest Politician's Guide to Crime Control. And their message was that much of what politicians do in crime control is based upon knee-jerk reactions or populist ideas, not on understanding what works. So we ought to use things that we know will work. We need to accept that addiction is a brain illness, that long-term treatment gets the best outcomes, that it can be coercive, you don't have to make it voluntary, and drug drivers need, at least the ones who are addicted, need long-term coercive treatment if we're going to change the drug driving problem. So I leave you with another quote from Alan Eschner. Addiction as a chronic, relapsing, remitting disease of the brain is a totally new concept for much of the general public, for policymakers, and sadly for many health professionals as well. So if we're serious about the drug driving question, we need to take what we know about the drug driving population and take what we know about what will work and come up with more sensible policies. Thanks very much.